Hello,
Go for it.
everybody. I'm very happy to be talking to you today. I wish that I could be talking to each one of you face to face because I think with your varied backgrounds, this would be a very good discussion that we would have, and I'd probably learn more from you than you would from me. When I say in the title of this that it's a presentation for therapists, that doesn't necessarily mean that you have to have the background of being a licensed therapist, but anybody who sits face to face with somebody dealing with addiction and talks with them and is helping them, this would definitely apply to you. So it would apply to physicians and school counselors and social workers and people that are helping within the hospitals and clinics, things like that. Um, I'd like to do a spoiler right now and go straight to the end of my presentation and say that something you guys probably already believe and that I've come to believe is that what we are treating here is not uh, the substance. It's not the alcohol, the opioid. It's the emotions that are triggered by traumas that cause fear and rage and shame and confusion and helplessness. That then that subconscious brain has placed those substances in a place of absolute safety. Even though it's an error, it's wrong, but it's placed it there. It's not a matter of right and wrong or morals, but that subconscious brain believes with all of its little heart, that little brain in there, that it's going after safety. And that as we focus too much on life coaching and on getting over the habits and making new goals, while those are all important, we can cause a disconnect between our smart upper brain. And that's what we're using right now as we talk to each other and you guys are listening to my ideas and you're thinking about them and incorporating them into your ideas and thinking of your opinions. That's intellectualizing. That's all here in the upper brain. If we are not taking care to manage the safety needs of our primitive brain, our lower part of our subconscious brain, we can cause a disconnect where it actually begins to distrust our upper brain. It begins to distrust what we're thinking. And so keep that in mind. I'm going to bust through these first few slides here because these first few slides are statistics and kind of talking about what I do as a detox doctor in our detox. But I want to get to that point that I just mentioned here, that spoiler. I want to get to the end of my presentation and talk about that more and get your guys' opinion on that. So we'll go to the first slide here. Let's see. There we go. Let's see if I can move my own picture out of the way here better so I can see. In 2022, Utah ranked number 4 in the nation for opioid-related overdose deaths. Isn't that crazy? 1,000 plus people died in Utah due to drug overdoses in 2022, with opioids contributing to 65% of these deaths. 23,000 plus individuals in Utah are estimated to suffer from opioid use disorder. Recent efforts to combat opioid use disorder have led to a decrease in prescription opioid abuse, but an increase in fentanyl use. And this has been a crazy fast transition from 2019 till now. We're talking about 900% increases in fentanyl use year over year. I mean, it's unreal. And that goes from different sources, but from the state patrol's amount of fentanyl they've captured has gone up 900% year after year. So it's unreal. And fentanyl is many times more powerful than heroin and many times cheaper than heroin, many times cheaper than oxycodone. For alcohol, 13.7% of Utah adults reported heavy alcohol use in 2021, with a significant increase in the past decade. Now, Utah has a higher rate of binge drinking than the national average, with 25% of adults reporting binge drinking episodes. 70% of Utah's substance use related deaths involve alcohol use disorder, with a lot of those being vehicle deaths or drownings, things like that. But a long-standing statistic is that 80% of all physical assaults and sexual assaults involve one of the people being under the influence of alcohol at that moment. I mean, imagine if 80% of all people involved in assaults were taking Tylenol at the moment, or taking a blood pressure medicine. That thing would be off the market so quick. But obviously, we like our alcohol, so it's here to stay, I think. But it's related in 80% of all assaults. The state is seeing a rising trend in alcohol-related car accidents and deaths, with over 300 deaths annually. And just so you guys know, the opioid overdose is now the leading single cause of death ages for under 45 years old in the nation. So it's a leading cause of death. It's beyond car accidents and everything else is the opioid overdose. Now, this is what I care about a lot. The consequences of addiction on the person's personal ability to appreciate their hobbies and their life, the effect on their family and family strain, the disappointment among the spouses and the children, and the huge contribution to divorce, the employment impact. Absenteeism is a huge loss of resources for the community. It's a lost day of that intelligent person helping their company and helping the community. It's gone because of that, and that value is extends well beyond the salary of that person, that benefit. So it's a huge loss each day that we lose. And the social impact, the person loses their friends. They end up with associating with different people. Each year goes by, less and less people that aren't using want to hang out with them, and they end up surrounded by a group of people that isn't positive for them, and they lose a lot of relationships. And to me, that's what I measure the outcome of success, is these things, not necessarily abstinence is the primary measure, but how much we help them improve these things. So opioid addiction, opioids bind to the mu receptors in the brain, providing pain relief and feelings of euphoria. Over time, tolerance builds, and the body requires more to achieve the same effect, leading to physical dependence. And the body makes a natural opioid called endorphins. That's actually
what about
stimulates
class, sweetie?
And then withdrawal symptoms include severe pain, and the pain is really severe. It causes quite a bit of fear among the people withdrawing, anxiety, nausea, and cravings. And then alcohol affects neurotransmitters, particularly GABA and glutamate, leading to sedative effects. It disinhibits them, makes you lose your anxiety, and you feel brave. Chronic use alters brain chemistry, leading to tolerance and dependence. Withdrawal symptoms include anxiety, tremors, seizures, and potential death in severe cases. So I now am the director of the detox facility associated with Aspen Grove Behavioral Hospital. And that's what I do on a day-by-day basis. And hopefully you will meet people in your work that you can send to us so we can help them detox. Detox helps by stabilizing the patient, and we prevent medical complications like seizures, heart attacks. The heart attacks actually come from severe electrolyte imbalances that happen when people try to detox in their own homes. They often they're not eating at all, they're not drinking, they're having diarrhea, they're vomiting. They get these huge electrolyte imbalances leading to heart attack. So we reduce withdrawal symptoms with our medicines. We don't use methadone in our clinic, but buprenorphine and then Valium and other medicines that dramatically reduce the withdrawal symptoms and help the brain come down safely. Safe environment, including constant monitoring by nurses 24 hours a day, as well as I'm on call 24 hours a day. And then we create a therapeutic setting. So we have groups that the patients really appreciate, and therapist visits. Again, for those of you that you are joining right now, I'm busting through these first few slides to get to the stuff that I really want to talk about more in depth and share my opinions on. The advantages of medically supervised inpatient detox as opposed to doing it at home or unsupervised. It mitigates the risk associated with withdrawal symptoms, including severe medical issues. We have higher retention rates, meaning that people that are willing to keep going afterwards are much higher when they come through a detox than if they try to do it on their own. The chance that they'll end up at a long-term rehabilitation center are much better when they go through a detox first with us. Comprehensive support, so as well as medical, patients are all seen by psychiatric service with our team, and we are able to diagnose things like depression and trauma PTSD, anxiety, bipolar, schizophrenia, even those kind of things, and able to provide them with contact to all the different resources in the community, especially the different rehab companies. Our treatment is effective in helping reduce the likelihood of relapse compared to abstinence-only detox, where they just have no medicines. Now, there's problems with short-term or sobriety-only programs where patients, ours is definitely very short-term, we're 1 week or so, and sobriety-only programs. And I'll talk to you about the ideal here in a second. But there is increased risk of relapse when you have a short-term treatment program compared to long-term. We don't have time to really teach the person much, and they're in a state of withdrawal. So their brains are pretty distracted while we're taking care of them. There's been shown to be an increased risk of overdose if people detox but don't get any support afterwards. So that's the real key. We're essentially like the ICU. If somebody came in a diabetic coma, or if somebody came in unstable congestive heart failure, we take them to the ICU and we stabilize them. We bring them to a place where their body is stable. And that's when the healing is supposed to begin, at that point, after we discharge from there. Our service is essential, but it definitely is not the healing. The healing needs care over a long period of time. Unfortunately, a lot of people want to try to do it on their own, and they just head back out into their own life without any help. And that would be like sending someone who came in a diabetic coma out with a little bit of advice and saying, yeah, just don't eat carbs and here you go. That's not going to work very often, maybe 10%. And same with congestive heart failure. You just say avoid some salt and exercise, don't drink too much water. 90% of those people would end up back in the ICU. And that's the same thing we see. If we don't have a good program of support afterwards, they'll come back. So the importance of long duration treatment, the studies are starting to pile in right now over the last 5 years or so with an increasing rate. All of them agreeing on the fact that 30 days has very little long-term effect, 90 days has very little long-term effect, talking about length of treatment, 6 months, not very good, 12 months, a little bit of good, a ton of good when we start to hit 15, 18, 24 months. Then we really see long-term retention and abstinence. And this goes along probably with what we see a lot in studies of the time it takes to heal from trauma. People want to come in and get 5 episodes of therapy for trauma, and that's barely even opening up the issues. It's not healing them yet, and that fight or flight subconscious brain takes a long time, like 18 to 24 months, and that's where we start to see good success. And I'll talk to you a little bit about what that would include. Medical,
Tomco,
yes.
we have a question in the chat. Lisa's asking, how does one get long-term treatment? It seems that insurance companies don't cover long-term treatment, and it's expensive to pay on one's own.
Well, the key for the medically assisted treatment, which I'm about to talk about right now, is for more family doctors to get involved. And the reason I say that is because the insurances never complain about paying family medicine codes. Almost never. I've almost never had to deal with denials for people seeing me for any reason under family medicine. So I can treat with long-term medicines for opioid addiction and alcohol addiction as a family doctor and bill, and they don't get denied. I could see them 150 times over 2 years and they pay for all of them. The problem is this type of patient is fairly demanding emotionally, and the schedule of actually programming in frequent enough visits to help them stay away from the substance and get over that is difficult to incorporate into an existing busy family practice. And so 2 years ago, the Biden administration wiped out all requirements for reporting to the DEA and to limiting your amount of people you're able to treat. They were hoping to take away barriers to allow family docs to get into this. And what they were seeing at that time was only 5% of zip codes in the United States had enough people prescribing like buprenorphine and the different medicines that we have naltrexone, and both of these help in alcohol also. The new studies are showing they both help with cravings and alcohol, and things like Wellbutrin, the medicine, the antidepressant, anti-anxiety medicine that helps with norepinephrine, dopamine, helps with cravings and things like that. They were hoping to see a big burst in that. I don't see that really happening very quickly, but that's the answer. Nurse practitioners and family doctors are the ones that can bill without much resistance. And there's no diagnosis in all of medicine that doesn't fall under the specialty of family medicine. I can treat hypertension, heart disease, diabetes, and addiction, and anything else, obstetrics. I mean, there's nothing that I can't do, and we never get denied. And that's really the key. As we see addiction specialists try to get into it, many insurances don't want to pay for more than a few sessions. You know, that's a problem. I've also seen some family doctors pick up with therapists combined together. And because the insurance won't pay for unlimited therapy visits, but they do pay for unlimited family medicine visits, they do a therapy session. The doctor pokes their head in and asks how things are going, and then they bill under the doctor code. And that's a good trick. You therapists may want to think about trying to buddy up with nurse practitioner or family physicians, and then you can buddy up like that, and you can use life coaches. Anybody can buddy up like that, and then they bill under the family medicine code. But that's complex, and that is a problem. And the insurance companies are paying for the medications now pretty well, and Medicaid pays very well, and Medicare. Now, here's what I want to talk about more. I'm just going to slow down now. I know I've been talking fast. I wanted to get through those first slides, and now I want to slow down a bit. And I'm actually moving into your guys' terrain. This is where therapists deal with and thrive in and struggle with every day. But it's something that I'm very interested in, and that as a physician, I've seen this topic is in reality the underlying core thing that we need to treat in order to help addiction, as well as trauma treatment, PTSD, as well as helping depression and anxiety. So complex trauma, which is about repetitive trauma, usually childhood, but it can be anything that's repeated enough that it starts to affect the way the brain thinks, that the brain has been punished over and over in a negative way. Put a person at much higher risk for substance use disorders. Substances like alcohol and opioids are often used to self-medicate unresolved trauma. And man, they work good in a very bad way. They work really well for an hour or two to take away that pain, that suffering. And that's why people end up using those. Think about it. We can detox somebody and send them to a 30 or 90-day program, and their body has no longer is tolerant to those drugs and doesn't have withdrawal anymore. It's not a physical issue. That is for the initial week or two. But why does somebody feel cravings 3 months later, 6 months later, a year later, 2 years later, when they come under stressful situations? It's not a physical addiction. It's an emotional need for safety. So the impacts on recovery: trauma must be addressed to achieve lasting recovery. Treating trauma often improves long-term sobriety. And I would say that if we actually gave proper trauma treatment to everyone, it would be the massive impact on long-term of addiction. So there's intergenerational effects of trauma. It's passed down through generations, through parents, and what I would say, and what I'm going to talk about here in a second, is that often trauma is not identified by the family or by practitioners, even therapists. A significant trauma that could affect someone for life could happen, for example, when that kid's 3 years old, and the breadwinner of the family, the mom or the dad who's the breadwinner, ends up having financial troubles. And then they find out there's a job available in another state, and they have to pack up the house, and the other parent's very busy. And the family's happy, two wonderful parents, but have a stressful life event. And that 3-year-old comes with distressing emotional issues to those parents, and they say, go watch TV, go watch the Disney movie. And during that several month period, and they finally move, and now they're trying to reestablish in a new location. That's a very common life experience. And no one would have said that that family had trauma like sexual molestation and assault and IV drug use in the household. I'm not talking about that. People would think, well, that's just normal. That happens to everyone. And even that person would say, I had a happy family. Everyone was happy. But the subconscious brain is a separate person. It is not the same person as our smart intellectual brain up on top here. It's a separate brain. It's a primitive brain. They don't communicate to each other. And that had an experience that its survival was threatened because its caretaker didn't see their distress and take the time to talk to them. That's the kind of trauma that I think actually has a bigger impact on future life, on good, healthy things like marriages and jobs and friendships than the big T traumas, which are being raped or being a military person and seeing someone shot to death right in front of you or something like that. These little things are hard to recognize, and we don't know why we keep having self-destructive behavior. But they absolutely cause feelings of fear and distress to go down to our body. And then the number one thing we start to crave is safety. And that subconscious brain has put fentanyl or heroin or vodka as literal safety, as that is safety. And so now we're trying to convince this little person in there, this little brain, that what it considers safety, we want to quit doing. It thinks we're walking towards a cliff and going to jump off. It thinks we're stupid. It thinks we're going crazy. And so it starts to increase its stimuli for us to go use that substance. You can't white knuckle it with your upper brain and be tough without even further traumatizing your subconscious brain. So someone can white knuckle it with lots of motivational speeches, lots of good goal setting for 6 months or a year and have had zero healing to the subconscious brain. So when I talked about earlier needing 18 to 24 months of healing, we're not talking about 18 to 24 months of sobriety. That might be equal to zero healing. We have to figure out what will make that subconscious brain feel safe. Now, a lot of that is therapy, but part of it is medicines. We do know that buprenorphine creates a safe environment for that brain while letting it lose the need for oxycodone and heroin and fentanyl. Acamprosate and naloxone, naltrexone can help with the same thing with alcohol. Okay, let's keep going here. And I know there's going to be some good conversation. So the fight or flight system in addiction. Opioids and alcohol activate the brain's reward system, relieving feelings of fear and anxiety and stress. And both substances may be used as self-medication to deal with past trauma or current emotional pain. Over time, the brain associates these substances with a safety, a relief, and reinforces that addiction. The subconscious response to trauma, the primitive brain controls immediate reactions to fear, anger, or pain, influence our coping strategies. Opioids and alcohol hijack the system, providing immediate relief, but perpetuating long-term addiction. And as far as we can tell, the fight or flight part of our brain does not communicate up to the intelligent part of our brain. It communicates down to the body. And the blood vessels in our muscles start to dilate. The rate and contractility of our heart starts to increase. The blood supply to our guts decreases. Our pupils dilate. And then our upper brain recognizes all those feelings as danger, and it starts to intellectualize, starts to survey the environment for the threat. And often it identifies your spouse as the threat, or your work, and it's a great job, but as the threat, or your friendship with somebody as the threat. Because it wants to assign something. It feels very uncomfortable not defining its world. And so when these feelings come, but in reality, something similar to something from 15 years ago, 30 years ago, was just triggered by this very low intelligence primitive brain that sent those feelings down. It's essential that we start teaching our addiction patients about that and the fact that almost 100% of the conclusions our intelligent brain will come to are wrong. They're not correct. They're error. And when they understand that, they'll stop feeling crazy. They'll start realizing that it is a feeling to their from their subconscious brain having a memory. I believe we need to start addressing trauma as the core issue of addiction. Trauma-focused therapies such as EMDR, trauma-focused CBT, and somatic therapies. Treating the trauma at the subconscious level reduces the need for substances to cope. So like I have mentioned before, the healing will start the minute that the subconscious brain actually feels safety. Medicines can help provide that. They can help with that, like buprenorphine is an example of providing that safety. But when the patient understands that it's not about coming up with a strategy of how never to use again and being tough, but rather to identify this little person in them that had traumas and how to make it feel safe, the whole mentality changes. It's not sobriety-based success or failure, it's healing-based success or failure. And when you know that you have a 2-year process or longer, and that reuse of the substance is not failure, it's just a learning opportunity, you can keep healing and healing. I think the problem with a lot of our programs up to this date is that abstinence from the drug was considered the only standard of success. And you got pins for 1 month and 6 months and 12 months. But we actually see very poor long-term success rates with abstinence-based programs. Long-term, meaning greater than 3 years, are in like the 10% rate. That's not good. We can really bring that up 5 to 10-fold with long-term programs, meaning 2-year type programs instead of 30-day programs. So the goal of that would be to help them identify that's signals from the subconscious brain, to not intellectualize that into definitions of who's the problem, what's the problem, but to let that feeling pass through them and start to desensitize the fear in that subconscious brain. I found that when the fear comes down, if the person's doing healthy things like working, maintaining family life and friendships, hobbies, physical exercise, fresh air, and getting outside, that the brain heals itself. We don't have a magic therapy that heals the brain. We don't have a magic medicine that heals the brain. The brain heals itself, but not when it's under a state of fear. And that's where the therapists have to come in and work their magic, help the patients identify that. We need to reduce the shame of relapse. One thing that happens as we create this never use again idea and this white knuckle it, be tough, be strong idea of not relapsing, what we're really saying to that subconscious brain is, I'm not giving you this safety. In fact, I'm going to do the craziest thing ever. I'm going to take that safety away, and we're just going to tough it out. So this subconscious brain is living under a constant activation. And what we start to build up is a neural potential of excitement, of energy with taboo, things that are not allowed or taboo. We build that higher and higher and higher and higher until on one weekend, the person's girlfriend leaves them, and then their boss fires them, and they get a speeding ticket. And all of a sudden, they have so much fear, they go reuse. And because we've built up this gigantic neural excitement, this potential of energy, when it goes off, that reinforcement to that subconscious brain is like, see, I told you all along that this is what I needed. And you resulted in zero healing. In fact, what you did was reinforce stronger than ever the opposite, that the substance really was the safety. So when we reduce the shame of relapse, when we tell people, hey, when we look at the most successful long-term programs for opioid addiction that use buprenorphine in a slow taper over 2 years and then have support all along the way, that those people on average reuse 7 times during those 2 years. And that wasn't failure. That was actually part of their success, getting there, part of their growth. And some people don't reuse, maybe 5 to 10% never use again, but the rest do. And the problem with an abstinence-based program is on day one, they'll say, never again will we use. Well, the reality is that's not true for 90 to 95% of patients. And then you've created this experience when they do reuse that reinforces very strongly the thing that the subconscious brain already believed, and that was that they have been unsafe this entire time, and alcohol or opioids was the safety. So whether we're an abstinence-based program or not, or we use medically assisted therapy with medicines, it doesn't matter. We need to reduce the shame of relapsing and make sure it's considered lucky if you don't, but expected that you will. And if we use that to learn from, what happens is very little neural excitement. There isn't a huge taboo built up, very little neural excitement. The person reuses in that same situation where they were fired from their job and their girlfriend left them and they got a speeding ticket, and they reuse, and they know that their provider, their doctor, their therapist said, hey, if you reuse, don't feel guilty about it. Just come talk to me. We'll talk about the triggers. We'll talk about whatever. Then they'll end up realizing it was kind of an icky experience. Like, oh, I was so proud of myself. I hadn't missed work in 4 months. Now I did. Oh man, I was so proud of myself how I was parenting my kids. And then this time my spouse came in and I was asleep on the floor and the kids were all dirty and running around and I was high or drunk. And it ends up being a net icky experience instead of a net relief. And that's what we need to create. And so, by time 7, that the person is reused during that period of time, there's almost no relief. And in fact, it's a feeling of ickiness, a negative feeling like nausea. And the person will be like, I actually don't want that. I like where I'm at. I don't want that. I'd rather talk to a friend, go on a walk, do my hobby, do these things. And so that's very important that we reduce the shame of relapse. In fact, we educate people that, hey, I'm glad if you never drink again, but the statistics say that most people will. And all I want you to do is come talk to me the next day after you do this. And we'll talk it through, talk about the triggers, talk about how it really wasn't that good, how it didn't solve any problems. In fact, how it made you feel worse overall. So physical manifestations of trauma and stress. I've talked about this a bit here. I got a little bit out of order, but that subconscious primitive brain communicates directly to the body. As far as we can tell, there aren't many connections between that part of the brain and the upper intelligent part of our brain, our reasoning, decision-making part of our brain. But there are many connections between that part of the brain and our body, our physical body. All those physiological changes I talked about. Think about it. If you ask somebody what it feels like when they have fear, they'll say, well, I feel afraid and worried about things. Like, yeah, but what do you feel? And if you get down to it, they're like, their eyes are wide open. They can barely breathe. Their muscles are tight. It's all physical feelings. You're like, well, what do you feel like when you're sad? And then we say, well, yeah, I feel really sad. I feel like a loss. Be like, yeah, but what do you feel? And it always comes back to, I feel my eyes starting to tear up. My voice gets tight. Can't get a breath in. I feel a big lump in my throat. I feel empty. I feel sick in my stomach, that kind of thing. Almost all of our emotions are actually what our upper brain's interpreting from the feelings of our body. And so it's very important to start working with your therapy patients. And again, you guys probably could teach me about this, but I find that some people don't know this, to carefully analyze the 1 or 2 seconds when they started having these thoughts about how terrible something is in their life, like their work or their job or their relationship or something, and ask themselves, did the feelings in your body start to come first, just 1 or 2 seconds before, and then went into the thoughts? Or are we already thinking about your problems and the feelings came? And I'll postulate to you that 90% of times that we spiral into panic attacks and we spiral into terrible feelings of betrayal and shame and helplessness and rage, in reality, the feelings started first. And what does that mean to us? Physical feelings, I'm talking about your body. That means that it wasn't from our intellectual brain. It was from the primitive subconscious brain. There's a disconnect there. And something triggered it to fire those signals off. And almost always, what we intellectualize to be true will be wrong. It's not correct because it's from the past. And so when we start to realize that, that is when that subconscious starts to heal and start to feel safe. Now, here's the problem with intellectualizing. Intellectualizing can go one of 2 ways. It defines our work or our relationship or our friendship or our hobby or I don't know, something as the big stressor. And so we avoid it. We don't show up to work that day. We fall sick, whatever it is. Or the opposite, we tell ourselves, hey, everything's okay. There's no problem. I'm okay. Everything's fine. We give all this positive self-talk. Well, remember that subconscious brain is a separate little person. And if it senses danger, and the first thing you do to it is tell it there's no danger, all it does is escalate its signals very high. And it takes 8 to 24 hours to come down. If we tell it that, yes, our boss is the problem or our spouse is the problem, it does the same thing. It escalates 8 to 24 hours to come down. There's nothing we can do intellectually when we have a very sensitive subconscious brain to help. All it does is end up in the exact same thing, terrible feelings that last for many hours. It ruins an entire day. So in that period when the subconscious is so traumatized, so afraid, so scared, which it's going to be when we start to take away alcohol, when we take away opioids, man, they're going to be more scared than they've ever been in their life. They'll be more scared than they were in the moment that they were being sexually abused, or in the moment where they saw something terrible happen. It's going to be worse than that. And so the only successful way that I've found, and you guys probably have a lot of other ways, there's a lot of meditation, sounds, touch, things like that, but is to stop right then and freeze that upper brain. So do not intellectualize. Don't say it's okay. Don't say it's not okay. Don't say anything, nothing. Say this is a feeling, it is a memory for my subconscious, and let it pass through. And then 1 minute later, 5 minutes later, 10 minutes later, 20 minutes later, sometime much shorter though, it's gone. And that has to happen 1,000 times. And then we're ready to start intellectualizing. Anyways, these are my opinions on your specialty. But I've ended up doing the last half of my 13 or 17 years, I guess, of family medicine. I ended up spending about 50% of my day working with trauma, with patients with depression, anxiety, bipolar, but with trauma as underlying issues with that. Okay, so I already talked about this a little bit, but very important, very, very important to help your patients realize that the little t traumas, like emotional neglect, and that doesn't, man, I hate even using these words like neglect or bullying, because the people receiving it and the people giving it often don't realize they're neglecting. The person receiving it doesn't realize they're being neglected. The person bullying doesn't realize they're bullying. The person receiving it doesn't realize they're being bullied. It's much more subtle than that, because at each stage of our life, at 3 years old, 6 years old, 9 years old, 12 years old, we have different necessities for survival. And if you look back 10,000 years ago and you were in a tribe of hunter-gatherers that lived a very dangerous and very tough life, and your caregiver, your mom, didn't give you emotional safety when you needed it at that point, that would probably be the biggest risk factor for your dying of anything. If you didn't have that support person, your chances of surviving, 0. Let's say you're 12 years old and you start doing things that really annoy everyone in your tribe, and you're about to be kicked out of your tribe. Your survival once you're kicked out is 0, and that's where the shame comes in. Shame's very effective at keeping you in the tribe. It makes you conform. And these days we're like, don't conform. Well, the reality is that idea wouldn't have worked 10,000 years ago in a hunter-gatherer tribe. You've got to not be kicked out, or your survival goes down. And the thing is, our subconscious brains don't even know that the year 2024 exists. As far as they're concerned, we're 10,000 BC. We are way long ago. And so these needs to survive are powerful. And when we don't have them, that trauma is worse than getting beat up. What affects your survival chances more 10,000 years ago in a tribe? Losing your caregiver, your mother, or being beat up? Of course, it's losing your caregiver. Rarely does being beat up ever kill you. Losing your caregiver kills you. And so that's why these little t traumas, put them into the context 10,000 years ago of a 1-year-old being neglected, not getting fed, of a 3-year-old not getting listened to, of a 5-year-old not being able to explore their imagination and truth and falsehood and tell a parent that and have them help define that, of a 12-year-old about everything being justice, right or wrong, and the black and white ideas of that. Each state is totally separate. And so these little t traumas happen to one of those stages. And as far as our body is concerned now, those are more dangerous than anybody pulling a knife on you. Or maybe that's equally dangerous. I mean, they're equally dangerous as that. That's pretty dangerous, but that's equal at least as they're your chances for survival. So we have to help people think of little t traumas, understand why that might make them feel so terrible, and why then that is their main reason that they want to go use alcohol. Absolute fear followed by absolute safety of drowning that with alcohol is what they're getting over and over. Has nothing to do with morality. Has nothing to do with choosing a partying lifestyle or a good lifestyle, a bad lifestyle, doing things that are healthy, unhealthy. And we can our brain likes to be healthy, our brain likes to be good and have a good lifestyle. The subconscious only cares about its survival in that tribe and its survival, in each situation. And doesn't think about morality. So it thinks of alcohol as a very, very good thing. And it thinks of fentanyl as a very, very good thing. And we're telling it that we're never giving it to you again. Yeah, that approach is not really helpful. In fact, I would say that's why we have a 5 to 10% long-term sobriety rate from an initial pass through standard programs that we've had. We need long-term help with that. So coping mechanisms often go awry. Now, you guys talk about this all the time. I think probably every single day in your jobs, you guys talk about coping mechanisms. It's probably one of the key things you talk about. They're very, very effective at helping us survive in the moment of a tough situation. They're usually not very good, though, in adult life in our good situations. Most coping mechanisms that we have at our job, from our life, are not going to help us in our job. They're not going to help us in our communication in our marriage, and they're not going to help us in our teaching of our kids, and they're not going to help us in not using alcohol. Things. So, very important to identify those coping mechanisms and realize what they are. Realize that they were wonderful things. They're not negatives about their, even though they're hurting them now. They were actually very wonderful things when they were 3 or whenever it happened, or 12 years old. Can you guys hear me? Okay, I just got a little sign on my thing saying my internet connection's unstable. Am I still good? Okay. So I'd actually like to open up. Well, let me see. I'll open up to questions and comments right now. I'd like to get this discussion going. And I think that's important because in this topic of medicine, I've come to realize as a doctor that the very most important part is what you guys do in your professions. And I'd like to talk about that a little bit more to teach myself also. If we were talking about the physiology of sodium in the kidneys, that'd be more up my alley specifically. But in this case, you guys are the experts. So what questions are there? Can I look on the chat here?
Yeah, you can look at the chat. It looks like we do have a couple questions that came in. I know Chuck was asking, do you perform an ACE screen as part of your intake or treatment plan?
So Aspen Grove Detox is a facility that's associated with Aspen Grove Behavioral Hospital. And we run the patients through the intake as though, in a very similar way, as though they're being admitted to the behavioral hospital for psychiatric and dual diagnosis issues and substance use issues. So they actually have a full history and evaluation from our psychiatric team when they come in, which is a big benefit. I know quite a bit, but definitely not as much as our psychiatric providers. And so if I wasn't associated with the hospital directly, we wouldn't have that. But they actually get an intake just like they were coming into the behavioral hospital with the psychiatrist, and they do use all of their tools, their diagnostic tools.
Great. And then Rochelle was asking, do the medicines help with other substance use disorders, like different drugs? I think what she's asking is, like, if you are prescribing a specific medicine for, a medication for a specific, maybe addiction, does it then cross over to maybe help with other substance abuse, issues as well?
Yeah. And so, and we're starting to learn that many medicines have the side effects of helping. But the main one we've used a lot for opioids is buprenorphine. It's very safe. There have been 0 documented overdoses of buprenorphine alone. 2% of overdoses have buprenorphine in their system, but it's the overdose on the fentanyl, not the buprenorphine. So it's been used in opioids heavily and very successful. It increases the success rates many-fold, doing a 2-year slow taper with buprenorphine compared to a quick alone taper. But we've also started to notice huge benefits on cravings for alcohol by using buprenorphine. And so we see back and forth with that. Naltrexone, which was used for both, and so we do see crossover on the cravings on both sides. Wellbutrin, the anti-anxiety antidepressant, has been shown to have. We first noticed it with tobacco, with nicotine addiction, is now being shown to help with opioids and alcohol. So there's actually a lot of crossover there, but there's a lot of new things like that are being researched, like ketamine and psilocybin. And those things are already heavily used in trauma and depression. So it's kind of interesting that a lot of the medicines we use for trauma and depression help with addiction. And here's an interesting one. I've started to find big success in severely depressed people with small doses of buprenorphine and naltrexone, which are addiction medicines. There's definitely a close contact in those areas of the brain between other mental health issues and addiction, and helping them both. But we're at the very, very baby stages of research. My guess is in 10 years from now, we'll have many, many more modalities than we do now.
Great. And then Lisa is asking, how does Adderall addiction track with all that you've been discussing?
Yeah, so Adderall addiction is really tough because if we look at adolescents who have well-diagnosed ADHD, and so they're not like the ones on the edges, but someone who's well-diagnosed, they're many-fold less likely to turn to alcohol and drugs, other drugs, illegal drugs, if they're treated with Adderall. So Adderall actually prevents addiction in most cases. However, with how it's become so easy to get Adderall, and the fact that general life stresses like going to college can qualify most people as ADD, even though it's not ADD, it's just fatigue and stress and poor time management and stuff. A lot of people have gotten Adderall that didn't need it. And again, that ability to think clearly, to get away from their anxiety, to essentially be able to cram short amounts of time, cramming a lot of productivity, becomes addictive. And I've actually met several patients where that was their gateway to things like alcohol and opioids. So there definitely is a danger to it. Like any other medicine, it really needs to be treated seriously. And I think the solution personally is telehealth. That was something I've really been feeling strongly about for a long time, was that telehealth was necessary because the medical system is so dang difficult. You have to take a whole half day off work and get a babysitter and wait in the waiting room for 2 hours, and the doctor's late, and then you get in there and you have 10 minutes, and then that was it. You just half a day for a 10-minute visit. And then the doctor also feels bad about that. It's not like they don't recognize that. So like, oh, I really would like to talk to you in 4 days from now and see how you're doing, but let's come back in a month, you know? And it's because of that guilt. I did that all the time. I started working with telehealth quite a bit before COVID, but with COVID came, we went to over 1,000 visits a month in my family practice of telehealth, and it kind of revolutionized things. And what I'm getting at here is when you start somebody on a medicine that could potentially be addictive, or they have an addiction already and you're treating them for it, you need frequent follow-up. You should be seeing them twice a week. And telehealth totally facilitates that. Because now when I started using telehealth, I would say at least half of all those 1,000 visits a month, the person was either at work or taking care of their kids or on vacation, or in the, they'd pull over, or they'd be on their 10-minute break at work and they'd have their doctor's visit. I got to influence them in a good way and get great data for safety. And they actually followed through with it. If I tried to get people to come into my office that often, it just wouldn't happen. The logistics would be too hard and people wouldn't do it. And so telehealth is the answer. So when I start someone on Adderall, I want to follow up frequently and frequently over time and make sure that my diagnosis is right, make sure that I don't sense addiction. And that's really the solution. But overall, Adderall, if we took all the people with ADD that I feel confident had ADD, they, and you give it to them in high school, for example, the number of careers that those same cohorts choose compared to ones that aren't treated is 4 times or more different variety of careers. So it really narrows their careers when they're told they're a bad student all the time, they can't concentrate and whatever. And it also manyfold decreases their chances of getting into alcohol and drugs because alcohol, cocaine, meth, heroin all treat ADD very well, different aspects of ADD. So that's a complicated question, but there's your answer.
Holes also asked a question here. It says, I would like to know your thoughts on methadone availability outside of a clinical setting, like in a private practice versus actual clinics that specialize.
Well, the data for methadone is just as good as for buprenorphine, and stub studies show that it even has better long-term effects if we're looking at receiving it and not going back to crime, for example, things like that. Currently, the reason it's not very great is you have to go to a methadone clinic, which eliminates a lot of normal people. When I say that, I hate to say that, but people that are functioning still in society, like a first responder, a policeman, and a EMT and a school teacher and a nurse, they don't want to get in line at methadone clinics. They don't seek help. And that's why those groups overdose more. If we can make methadone available to at least psychiatrists in their private clinics, that would be good, or addiction specialists. But I really think all family medicine doctors, I mean, most people don't realize that any nurse practitioner or family doctor in the entire nation is approved by the DEA to prescribe methadone for chronic pain and buprenorphine for chronic pain. You know how much pushback we get for that? Zero. So we can be feeding this stuff out there for chronic pain, but when we're trying to treat addiction, all of a sudden we can't. You know, it's interesting that we can't give it to get somebody to stop fentanyl, but we can give it for back pain. And so, but methadone is much more dangerous than buprenorphine. So at high doses, it greatly increases chances of fatal arrhythmias, cardiac arrhythmias, and it's at least as addictive as oxycodone, and it's much harder to get off of, to withdraw from. Like when we try to withdraw people with buprenorphine who are on methadone, oh, it's so hard, way harder. So there are a lot of benefits to it, but if it were available more to specialists, but it has a lot of drawbacks compared to buprenorphine. And in fact, I'm fine to stay beyond 1 o'clock. I don't know what the rules are. But I mentioned one person in here, and I probably know who she is, but C. Atkinson said we were providing treatment not only to the individual, but to their entire past also. I'd say that's actually the key. In fact, it's their past is probably 95% of what we're treating and not the present. And that's the mistake I think we've made a lot. We really need to help people cure their past. And the alcohol cravings will go away. That's small compared to the thing that's causing them to crave it in the first place, which is fear. It's not addiction to a party drug. Someone asked about genetic predisposition. The genetic predisposition definitely is part of tolerance, and that's where the body likes this substance, gets used to it, but now withdraws heavily if you try to take it away. That's what tolerance is. That's definitely genetic. So getting hooked in one use, which is actually very common with fentanyl, definitely high genetic component. Alcohol, we really know there is a genetic component to that part of it. But to the fear component and the subconscious issues, that's probably more tied to families that have anxiety or depression or PTSD and things like that.
All right. Any other questions before we end today? Thank you, everyone, for having joined us today. This was very informative. Thank you, Dr. Tomco, for your time. And if you do think of something, please shoot me an email and I will direct that to Dr. Tomco.
Yeah, thank you.